In 2003, my mother-in-law, Fervid, went from living independently in her own apartment into the healthcare center of her seniors complex. She'd felt ill, she'd had the flu, she ended up being dehydrated and was sent to the healthcare center for a few days of recuperation. What surprised us is that instead of Fervid getting better and returning to her apartment, she actually got a lot worse. She became confused, she started not recognizing us, she was having hallucinations, and we began to suspect that perhaps she was having a drug reaction. The antidepressant that she'd been put on, and one of the pain drugs that also affects serotonin in the brain, that these two were probably causing serotonin syndrome. And Fervid had many of the symptoms of that syndrome because these symptoms came up with the drugs. She didn't have them before these new drugs were introduced. So we met with the medical staff, presented our information, and they decided they would do a directed deletion of some of the drugs that she was on, and she recovered completely. Cognitively, she did not recover completely physically because she'd been, by this time, bedridden too long. She could not be discharged back to her apartment. One of the most important things about identifying these medication problems quickly is that an elder will lose 5% of physical functioning for every day that they are bedridden. So by the time they've been in bed 3 or 4 weeks, they are not going to be able to be functioning well enough that they can be discharged back to their home and back to independent living. Because of our experience with Fervid, I felt really inspired to try and do something about this problem. I was a little loath to do that, not being a medical person, but then I read a book by Dr. John Sloan, who has treated frail elders in their homes for over 20 years, and I understood that this is a widespread problem. And I now belong to the Polypharmacy Working Group, and we are developing continuing education on a provincial level for medical directors and medical staff in nursing homes to try and use the medication reviews to cut down on the number of drugs that elders are taking.
So polypharmacy, that's what we're talking about today, in various ways. What is polypharmacy? Is it too many inappropriate medications, too many appropriate medications? Is it more than 5, more than 10? Well, this is what I think it is. It's when the theoretical benefits of multiple medications are outweighed by the negative effect of the sheer number of medications, regardless of class of medication or appropriateness thereof. It doesn't matter if it's 15 antidepressants or 15 painkillers or 15 vitamin pills. The result is the same. Polypharmacy is a standalone risk factor for morbidity. That's a really hard point to get across when people want to discuss whether people should be on this to prevent that and this for that, is that every time you add a medication, you add risk to the resident. Average number of meds in residential care in BC is 9. It affects the quality of life and resident safety. You have a decrease in global health and cognitive function. You get an increased risk of ADEs, adverse drug events, and risk of falls. The adverse drug events lead to increased transfers to acute care, which leads to what Johanna referenced, hospital-associated disability, is that people, when they're in residential care and they go to acute care, nobody's taking them for walks. Nobody's taking them out into the courtyard in the sunshine. They're just lying in bed, getting pills rammed down their throat. If you're on 5 or more pills, you have a 10% chance of an acute care visit per year. 7 or more, it's 20% chance. 9 or more, it's 30% chance. And to me, that outweighs the 0.5% chance where you can reduce somebody having a stroke by being on a statin. How do we get to polypharmacy? We treat symptoms in numbers. We treat blood pressure numbers out of context. We treat side effects of a pill with another pill. We have telephone or fax-based medicine. Lack of evidence for chemoprevention of various things, but we just extrapolate on from studies done in 50-year-olds. Discharged from acute care, we don't know why they're on the extra drugs that they've been put on in hospital. And one big thing is lack of awareness of medications that are anticholinergics, which cause all kinds of problems. So, with this project, we have engaged various areas, and our sort of cornerstone was that each area is an individual area. They're totally different. So we visited the areas and asked them what they wanted. There's an overwhelming appetite for this polypharmacy reduction amongst the physicians, directors of care, pharmacists, and families. So we have a process that allows you to reduce the medications, and Chris will be not speaking to this, but we will demonstrate how that works. We don't just engage family practitioners or specialists, but we involve the directors of care, the pharmacists, the residents, and the family. And we call this the circle of care that we're trying to address. And when we do go and visit the places, we stimulate a lot of conversation amongst the folk who discuss the process, whereby they can incorporate our method of polypharmacy reduction into their practices. So, you're all supposed to write that down, I think. But I wouldn't bother. How does it work now? Oh, it's okay. I'm only kidding. I just wanted you up here. So what we're now going to do is watch a video clip of Chris explaining how we propose this can be done.
I'm going to highlight the clinical support materials put together for the Shared Care Polypharmacy initiative in residential care. In this first slide, we look at the opportunities for doing medication reviews in a facility. There are standard times, such as the twice-a-year medication reviews done through pharmacy, where a pharmacist and a nurse will do the reviews, and perhaps a medical advisor. In addition, there are opportunities when someone's admitted. And over and above that, there are opportunities when someone's having a period of decline, such as a fall. And we have been discussing this with people in the prototypes, and they think that this is going to be a valuable approach for them to know where to focus their efforts. Now, we found in our discussions with the people involved in the various areas that there are a number of considerations. Certainly knowing what the evidence is important. But also knowing that there isn't direct evidence for most things in frail elderly, we have to look at an interpretation of evidence. In addition, when you change medications, you're going to want to do a monitoring and review, and that takes time. And there's concerns about that. But balanced off for that is the time to actually do medication administration. So if you're reducing medications, then you're saving time on that side. In addition, another concern is about the promotion of non-pharmacologic approaches for managing situations such as behavior change in the residents. That takes time and a certain skill. But that's balanced off by the adverse events that are caused by medications, which takes time as well. So that's important to remember. Very important is the consideration of relating to the resident and family to be involved in decision making. And we'll be looking at that as well. Now you'll see before you a diagram, which is a drug algorithm generated from a research study, because we wanted to look and see whether there was evidence and approach that we could use as far as doing medication reviews. This has been retailored a little bit to match the clinical process that I felt that we would use as physicians. You'll see that there's general considerations, which is looking at the general evidence in the population, then in seniors and frail elderly, but also looking at adverse event profiles. And then looking at the risk-benefit ratio in relation to that to help with your decision making. Then you take that information and look at the individual resident that's under review and see what the indication for medication is, what adverse event profile they might be having, and then you can make a better decision about medications for that particular individual. Now, we've put together a number of different clinical materials to support decision making. A very important part of that is the drug advisory sheets. And the drug advisory sheets are in a number of different drug categories that we felt were important to specifically target. And they take an approach that follows the algorithm, looking at the evidence, the adverse event profile, and risk-benefit to provide support for decision-making. In addition, there are condition advisory sheets, which more generally look at certain conditions pertaining to seniors, in addition to for residents in residential care, but general seniors as well, which were felt to be important to address. You'll see in these next two slides that the highlights of recommendations that are in the drug advisory sheets. I'm not going to go over all of them, but you'll see that it's not always about discontinuing medications. In many situations, you're trying to reduce the potential for adverse drug events, so you may do drug dosage reductions, such as for antihypertensives. In addition, some medications aggregate together, such as medications for osteoporosis, and so recommendations are done in relation to that as well. In the final sheet, there's an aggregation of medications used for psychiatric conditions, where really it's a balance of using non-pharmacologic approaches with the appropriate use of medications in residential care. And so we have advice as to that. So thank you very much.
Okay, so remember, this is a showcase. This is not a didactic CME thing.
Chris, isn't that the same shirt? Yeah. I thought about that, Bill, but it's not. My posture's better.
It's like cavers, right?
Yeah.
Okay. So our next thing we're going to do is a showcase. So I thought we were supposed to show you what a wonderful grand job we're doing places. So we did some video clips from 3 different perspectives. Now, it's all in the same health authority. That was for convenience rather than just planting them there. So the first one is Linda Chase, who's a manager of care in Fraser Health.
I was invited, along with a group of other physicians, nurses, pharmacists, by Dr. Ralph Jones. I found it very useful. I found it informative. I found it because I think polypharmacy is a problem in residential care. I found the information that was at the education session useful, particularly the algorithms. The other reason I found that the Shared Care initiative was useful is that it wasn't directed just at physicians. It was meant for multi-professionals, including pharmacists, nurses, residential care coordinators. In my facility, yes, my RCC, which is my resident care coordinator, and Dr. Brody, who is my medical director, spoke about this initiative and how we could actually apply it to residents and use the process in Bradley Center. Three months ago, we held 2 medication reviews, one by Dr. Ralph Jones and one by Dr. Brian Brody, where we reviewed all medications under a med review. At that time, with 90 residents, we reduced the medications by close to 200 medications across Bradley Center. At this point in time, there has been very few medications that have been reinitiated, mostly antipsychotics and some respiratory drugs. But on the whole, we've found the process, looking at the statins, looking at hypertensive, looking at a number of drugs through the algorithmic piece around CSI to be extremely helpful. Residents feel better, costs are down, residents are not being, nursing staff is not being, spending all their time giving out pills. So as a long-term or as a short-term intervention, this has been really good. Whether it will hold true, whether we can maintain these gains, I won't be able to know for a year. Yes, anecdotally, the family members have said they're interested in this, they understand the process. Dr. Brody gave a lecture to, or not a lecture, he provided information to a number of family members. I think there was probably 14 family members there, and they were very interested, asked good questions, and yes, anecdotally, I think they found it very good and understood the reason for reducing polypharmacy in residential care. I do think it would be a good initiative to continue to assist us as we move forward, assisting in the process as we move forward. Continuing education, bringing up, providing this initiative in an education session for more physicians. The nursing staff, I think that's really important. I think also pharmacists would benefit from this whole process. And again, possibly bringing family members into the idea around polypharmacy. It's been an extremely good initiative for Chilliwack Hospital and Bradley Centre specifically. I think in residential care in general, polypharmacy is a problem, and I can give you a whole pile of reasons why why polypharmacy is a problem.
So the next perspective is from a medical director for Fraser Health.
In Fraser, there are more than 60 physicians serving as facility medical directors, along with hundreds of other physicians who look after individual patients that are in residential care. In total, there are over 8,000 residents in residential care in Fraser. As a program medical director for residential care, I need something that addresses the issue of polypharmacy, something that I, along with facility medical director colleagues, can champion. And that something needs to be clear and easy to use, but it needs to be the result of rigorous review with clear application to quality care in residential care. It needs to be practical, including guidance to safely reduce or eliminate unnecessary and inappropriate medication. When I first saw the materials, I was really impressed and wanted to share that with colleagues almost right away. I did get a response back recently from a colleague who will be joining us as a facility medical director, someone with a lot of experience in residential care in another area. And I'd just like to read what he sent back in an email. His comment was, "This is excellent. I have tried to focus on individual classes of drugs, benzodiazepines, antibiotics, when I have tried to address polypharmacy in the past. This global approach is much more effective. Some people put an enormous amount of very good work into this. Thanks for letting me see this. I would very much like to be part of this initiative." And as a program medical director, this is the kind of resource that I need. In my opinion, the Shared Care Polypharmacy initiative provides clear rationale and support for enhanced medication reviews, with the associated benefits that are there for residents, and not only for residents, but for their loved ones as well. A key challenge, and I think a key factor in success in addressing polypharmacy through enhanced medication reviews, will be quality information for care facility residents, families, and friends. Family members' perspectives on the value of certain medications, some that may have been used for 40 years or more, may differ from ours. Care team members may also be concerned about seeing some medications eliminated. Tools to assist in communication with families, focusing on quality of life and quality of care, will be critically important. So will tools to assist in communication with our partners in care.
So after seeing those two, the only question you must be asking yourself is this a great shared care initiative or the greatest shared care initiative? However, we thought we'd get a grumpy Welshman to bring us back down to earth a little bit.
As the director of 2 care homes, polypharmacy is part of our quality of care and its reduction. I'm responsible for the quality of care. But it's not just the quality of care, it's a quality of life issue, a quality of life for my residents. I've seen dramatic differences in the quality of their life when the burden of their medication is reduced and they're on less medications. There's a number of challenges. Firstly, with my colleagues. Some of my colleagues have been reluctant to engage in the polypharmacy reduction. They find it easier to take the line of least resistance than perhaps deal with a long explanation or an argument with relatives. It's hard to get the topics fixed in their mind, for example, of the number needed to treat, the differences in the use of these medications in the elderly, and the benefits of reducing polypharmacy. Not just with my colleagues, but this extends across the care home with the care aides, particularly those on the front line. Some of them are reluctant to see the medications taken away, particularly if they're tranquilizers or other sedatives. But overall, the biggest issue is it's a system issue. It's hard for me to deal with individually, but all of us, I feel, should be looking at how we deal with medication in the elderly, from GPs, care homes, emergency departments, and hospital admission, and also at the transition points, which is really important. Oh yes, very much so. It's been very useful to have enthusiastic and interested key participants in the care of the elderly together in one room. We build on each other's energy. We learn from each other, and when everybody's together on the same page, we understand each other's problems, then we can go forward and start looking at meaningful involvement in the programs. No, it's been extremely useful. Well, the materials are still in development. They've been personally useful to me because I've been able to use them if there's a question from a colleague. But they aren't yet developed enough that I could hand them out to colleagues. They need to be both simplified, to provide a summary, and they also need to have an in-depth review and bibliography that's available for my colleagues. I think that that's an important next step for us. I'd like to see the development of a multi-level marketing or advertising campaign for shared care. I'd like to see us take a lead from the very successful program of Bugs Don't Need Drugs. I think that that's changed in admin speak a paradigm. And the Shared Care Committee could help by bringing the key players together, by acting as a coordinating and also as a body that'll push us forward. You know, busy doctors, we sometimes feel that we've reached a certain point, but we need actually to be pushed to get even better at this sort of reduction in polypharmacy. We need a change management approach, and we need people who are used to running change management to help us. Yeah, and this is exciting. The more people you meet from other provinces, just last weekend I met people from Saskatchewan who've sort of independently have almost, well, exactly the same ideas and are developing materials. We can share these, and if we have this as a movement across Canada, and the Shared Care Committee helping us to link these bodies together, we've got a lot that we can learn from each other, and ultimately apply for the benefit of our patients.
Okay, so we've run out of time, so sadly we don't have any time for questions, comments, or even opposing statements.